Trainees, I think, and actually consultants who are interested in perioperative medicine, we need to, in a way, get out of the operating theatre. We need to sort of think outside that zone. I think we need to understand who are the high-risk patients, for example, and what their true risk is. You can find out sort of nationally by reading reports from NCPOD. Actually, Rupert Pearce, for example, has written about this. What about finding out or looking in details at the guidelines for how we should investigate and what the evidence is, investigating the heart before non-cardiac surgery? What's the evidence for doing a static transthoracic echo, for example? How does that help us? Does it help us? Does it not help us? What about looking at CPECs if you're a trainee? Does that help us? Does it not? What's the evidence that it helps us? I think to start with perioperative medicine, you can look at certain areas and with a critical and sort of slightly cynical eye, not cynical is the wrong word, but with a critical eye, you can look at what the evidence is that these in real life are useful tools to help you and the patient and the surgeon decide together how to proceed with the patient about to have surgery.
I suppose the most important thing is, which trainees does perioperative medicine have importance to? The answer would obviously be any trainee that comes into contact with a surgical patient. So that could be surgeons, it could be anaesthetists, it could be physicians as well, and particularly obviously these days elderly care physicians too. What do trainees need to know about it? It's a holistic approach to the management of patients having surgery, so it should encompass all aspects of the perioperative pathway, from the time that patients are trying to come to a decision about whether to have an operation or not. That can go all the way back to primary care, through to potentially the long-term consequences of the surgery, the anaesthesia and the perioperative care that they receive. And the holistic side of perioperative medicine means that all sorts of healthcare professionals should be involved in its delivery, not just doctors. So across the medical specialties, as I've mentioned already, medicine, surgery, anaesthesia, elderly care and primary care should all be involved, but also other allied health professionals, so physiotherapy, psychology potentially, helping patients to understand their risk and also helping them to understand the consequences of having surgery or not having it. All of these allied health professionals can help us in the delivery of perioperative medicine, and particularly obviously the nursing staff as well.
It's important for trainees to learn about perioperative medicine in a scope that's larger than the FRCA syllabus that they're learning at the moment. So I think when you study for FRCA, you learn how to give an anaesthetic for a certain disease or a certain surgical condition, and learn about the pre-assessment for that, intraoperative care and post-operative care. In perioperative medicine, I think the idea is to look at it in a more global terms. So risk assessing the patient from the beginning in a more detailed way. Should the patient be having this surgery? Has it been discussed with the surgeon? Has it been discussed with the anaesthetist? Has there been shared decision making? Has this decision been made as a group? Using novel risk calculators or risk assessment tools that aren't traditionally taught in the FRCA syllabus as well. So for example, CPECs. What's the evidence behind it? Is it relevant? Other new novel calculators such as using PPOSM might be interesting. I think moving on from pre-assessment, it's important for trainees to have more of an awareness into their intraoperative management and how that impacts on patients. So for example, are you using cardiac output monitoring? If so, do you know how to interpret it, and does it have a bearing on the results? Are there certain drugs you're giving, whether you're giving a regional anaesthesia or general anaesthesia, how does it affect the patient? Not only how does it affect them 5 days after the operation, but how does it affect them 1 year after the operation? Does it have any bearing on outcome? And then post-operatively, looking at their care from a global point of view, I think primarily focused on the PACU, the post-anaesthetic care units, and seeing what interventions they give and how they impact on patient outcome.
Well, it's the future. I think if you want to future-proof your career and you want to engage in a specialty which is on the up, then I think perioperative medicine is for you. there's always going to be room for anaesthesia and practice of anaesthesia in an anaesthetic room within a theatre. But actually, I think the future is more about the anaesthetist getting out of the operating theatre, getting out into the outpatients, getting out there onto the wards, and actually beginning to corral, orchestrate and run the services. We've been waiting for this for a long time. As trainees, you should be very, very excited about the future of perioperative medicine and the role anaesthetists will have in that.
Perioperative medicine is important to trainees because it is part of our future. It's here for many people already. They already have an extended role and will be called upon increasingly to practice in those various different areas. Therefore, as part of being trained, one has to be able to perform as a perioperative physician. So its emphasis is going to be changed in the curriculum to mean that it's going to be clearly a core component of training.